Good morning, everyone. I am going to discuss case number 10. The history provided was 62-year male with complaint of pain in abdomen. Cytology slides was done from mesenteric lymph nodes. This Giemsa stain slide shows round to oval cells, as we can see here, which are large with abundant fine cytoplasm which is clear, and also eccentrically placed nucleus are seen which are having vesicular nucleus, and in few cells we can see the nucleoli. These are the cells which are not seen normally in the cytology or FNAC of a lymph node. So, coming to microscopy, it is a highly cellular Giemsa stained aspirated smear which shows large round to oval cells with clear abundant cytoplasm with fine vacuolations and eccentrically placed nucleus with vesicular chromatin, and few cells are showing nucleoli. So, the diagnosis is metastatic renal cell carcinoma. Coming to the differential diagnosis of tumors with vacuolated or clear cells include acinic cell carcinoma of the salivary gland, mucoepidermoid carcinoma of the salivary gland, clear cell thyroid carcinoma, clear cell tumor of the lung, mesonephric, that is clear cell carcinoma of the ovary. How to differentiate these clear cell tumors from the clear cell variant of renal cell carcinoma? It is either by doing special stain or immunohistochemistry. Cells of renal cell carcinoma contain intracytoplasmic fat, which when stained with oil red O on a air-dried aspirated smear, it shows positivity. For immunohistochemistry, the cells of renal cell carcinoma are positive for CD10, vimentin, epithelial membrane antigen. Renal cell carcinoma. Renal cell carcinoma is a relatively rare tumor accounting for less than 3% of all adult cancers. Its incidence is 4th in among males and 14th among the females respectively. Male to female ratio is 2:1. Etiology. The risk factors for renal cell carcinoma include obesity, smoking, hypertension, acquired cystic kidney disease due to end-stage renal disease, occupational exposure to trichloroethylene, treated neuroblastoma. Genetic susceptibility is estimated to account for 2 to 4% of the cases. Usually it is more than 50 years old. It is usually seen in persons who are more than 50 years of age. Clinical presentations are like hematuria, flank pain, abdominal mass. The combination of these three features is a classical diagnostic triad for renal cell carcinoma, which occurs only in 9% of the patient. Now coming to the fine needle aspiration when it is done, or cytological findings for renal cell carcinoma. Tumor cells may be in single or are arranged loosely in flat sheets or clusters or papillary fronts or an alveolar pattern. The smear pattern may occasionally be mixed. There are three distinct types of cells which can be seen in fine needle aspiration cytology. They are first clear cell, second granular cell, and the third are oncocytic cell types. Clear cell, granular cell, oncocytic cells. Sometimes we can even see the mixture of the three cells. The clear cells of renal cell carcinoma have abundant, fragile, finely vacuolated cytoplasm. Cytoplasmic vacuoles are punched out, bubbly or lacy. The partial extruded nucleus is useful identifying feature. The cell borders may be well defined but are usually indistinct. Granular cells have eosinophilic or cyanophilic cytoplasm which is moderately dense and granular. The third type, that is oncocytic cells, have extremely dense eosinophilic compact cytoplasm with well-defined cell borders. Tumor cells have abundant cytoplasm that is vacuolated, fluffy or granular, usually with distinct cell borders. Chromophobe renal cell carcinoma has distinct borders. Tumor nuclei have variable atypia, irregular counters, haphazard orientation with abnormal chromatin, variable prominent nucleoli. Renal tubular cells have well defined cell borders, homogeneous cytoplasm, round, regular, or orderly nuclei. Important features to distinguish from other neoplasms include heterogeneous cell population, small cytoplasmic vacuoles, and hemosiderin deposits. Coming to WHO classification of renal cell tumors. These include clear cell renal cell carcinoma, papillary renal cell carcinoma, chromophobe renal cell carcinoma, collecting duct carcinoma, renal medullary carcinoma, renal carcinoma associated with XP11.2 translocation, mucinous tubular and spindle cell carcinoma, renal oncocytoma, renal cell carcinoma unclassified. Coming to the few pictures, this is the image which is showing metastatic high-grade renal cell carcinoma. The clusters are poorly cohesive large cells with abundant pale cytoplasm with some vacuoles, relatively distinct cell borders. Large pleomorphic nuclei with prominent nucleoli are seen. Also seen are few mitotic figures. The second variant, this renal cell carcinoma, where the granular pattern of cluster of cells of epithelial cells with abundant dense finely granular cytoplasm is seen and malignant nuclear features are seen, that is pleomorphic nucleus with few prominent nucleoli. The third type, renal cell carcinoma, papillary type. Poorly cohesive small cells with round uniform nuclei, stromal fragments from disrupted papillae, psammoma body are also seen. Renal cell carcinoma, chromophobe type. Clustered cells are seen, majority with abundant granular vacuolated cytoplasm. Some much smaller cells are seen and moderate anisokaryosis, some cells with small nuclei. When coming to immunohistochemistry, the positive stains are PAX8, PAX2, CA1X, diffuse membranous in 75 to 100% of cells of clear cell renal cell carcinoma. Generally, they are CD10 positive renal cell carcinoma, Vimentin epithelial markers including AE1, AE3, CAM 5.2 and epithelial membrane antigen positive. Thank you.